Well, it's very nice to see everybody. Thank y'all for having me. Kind of as Nick said, I'm Dr. Wes Troyer, completed residency up at University of Kentucky, then did sports medicine fellowship down at Emory, and then now in Florida. So common theme in the fact that all these places are hot. So I tend to see a fair amount of heat stroke. But thank you all for coming to the September Journal Club, and thank you to AOCPMR for having me. Today, we're talking about cold water immersion, gold standard for exertional heat stroke treatment. So no disclosures. So my experience, kind of like I already went over, is a previous team physician at Emory, Decatur, been with multiple high school systems in Georgia, Kentucky, and Florida, worked on lots of kind of long distance mass events, especially ones in the heat, like the Flying Pig Marathon in Cincinnati. So had a fair amount of heat exposure, but probably the biggest heat exposure I've had is just the fact that I've lived in South Carolina and Georgia most of my life, kind of looking like Ace Ventura when he was stuck in that rhinoceros in the top right corner. So talking about this article, it's a little bit older article, but I thought it was really good because it kind of hits home with a lot of important points that if you're covering mass events, if you're covering football on Fridays, or even preseason stuff, that you got to know when it comes to cold water immersion, specifically related to exertional heat treatment. And so this paper was written by Doug Casa, who's one of the leaders in the field in regards to heat stroke treatment, along with kind of Fran O'Connor, one of the military guys. They speak on this all the time. He runs the Corey Stringer Institute, which, if those of you who remember, Corey Stringer was a football player for the Minnesota Vikings, I believe in the early 2000s, that passed away due to heat stroke, and they've kind of put his namesake on the institute up at the University of Connecticut, where they do a lot of the research in this field. And I think Doug puts it very simple when he says, if you cool someone right away on site, they don't die, period. And heat stroke treatment's something I truly enjoy talking about, because it's one of the true phenomenons in sports medicine that is 100% treatable as long as you recognize it early. And as a team physician, you can really provide significant help to those athletes in significant danger. And that being said, that's all you need to know. No, just kidding. We'll keep going. So when it comes down to cold water immersion, looking at this paper, I'll talk a lot about just kind of the basics of heat stroke and some of the things that you have to know when treating these athletes. And then finally, we'll get into some pieces of the paper that I really enjoyed. But really, this paper was looking at cold water immersion, stating that it should be the preferred method of treatment with exertional heat stroke because of its superior cooling rates and unsurpassed survival rates. They really emphasize the fact that they want to refute the claims or the thought process that cold water immersion can hinder cooling of hyperthermic athletes because of peripheral vasoconstriction as well as shivering. And then they also want to establish evidence-based protocols regarding the treatment of exertional heat stroke in accordance with best practice and evidence-based practice. So when it comes to heat-related illness, to first discuss treatment, we have to dispel some of these myths regarding heat stroke. We first have to understand what we are treating and what the process of this is. So heat-related illness was widely accepted as a paradigm that these medical conditions were heat-related, and they were a spectrum in nature at one point, which would make you at risk for developing one of them and then developing worse heat-related illness if you didn't recognize the signs early. And so when we look at these things, you'll hear about heat stroke, which is of course what we're talking about today, but also heat exhaustion, heat cramps, sunburn, heat rash. So it's important to recognize that these are not a spectrum. The fact that you start developing heat cramps, heat edema, heat exhaustion does not put you at risk for developing heat stroke if you don't stop. They're really the only thing that connects these is the fact that they both happen in the heat, and it's almost dangerous to assume that these are a spectrum just to make sure that you do not miss heat stroke, because it's so much more important to recognize than the other ones. Next slide. It'll go. And so when it comes down to exertional heat stroke, clinical presentation really boils down to two really important things. The clinical presentation of increased body temperature with a rectal temp of greater than 40 degrees Celsius, or here in America, 104 degrees Fahrenheit, and then mental status changes that are present. When we look at mental status changes, we're consider irrational behavior, irritability, emotional instability, confusion, or just the fact that someone kind of looks out of it. They're just not themselves. So it's important to know your players, know what they're typically like, and if they're out of it, that can even count as a mental status change. Easier things to recognize are seizure, incontinence, ataxia, blurred vision, things like that. But even just the look of being out of it or a little bit confused can tip you off to mental status changes that may help you diagnose someone with exertional heat stroke. When we're talking about temperature, we'll get into it later, but we always use rectal temp for this. And this is because the other methods of measuring temperature tend to be unreliable and always underestimate how high the body temperature is. That being said, temperature should never really be an exclusion for treatment of heat stroke. If you suspect it's heat stroke, someone's exercising vigorously in the heat, their temp is still 102, but they're mentally confused. Yes, you should be doing your workup. Yes, you should be considering other options. But if you think that they're hot, they're confused, put the rectal temp in, continue to monitor it, because a lot of times it will be low and could just be tracking up at that time, and treat as you would a typical heat stroke. When looking at heat generation during running and why this develops, mechanical energy converting into chemical energy stored as ATP happens while you run. 70% of this total chemical energy is released as heat. And then in runners or more efficient runners, this increases to about 90%. When we're looking at how our body gets rid of this heat so that we can stay in normal temperature, we look at sweat evaporation, which is the primary cooling mechanism in most people. Heat carried off by convection with wind or the weather around us, the air to kind of body interface helps carry off heat to surfaces of lower temperatures, and then conduction, which is just heat transfer to garments that you're wearing, which is a very low percentage of the amount of the heat we're getting rid of with our bodies. Of course, conditions on race day can drastically affect how we're able to regulate heat. As you can imagine, if there's lots of wind, you're able to convect heat off the body a lot more efficiently. If it's very humid, evaporation would happen a lot less, and then heat generated is going to be more in your athletes. Acclimatization, or your ability as an athlete to sweat, and your body's recognition of heat being generated in the body to adapt to that, is something we also take into consideration, as well as pace, which goes along with intensity. When we're looking at heat production, it's determined by the rate of the energy that athlete's energy expenditure, or their metabolic rate. And this really comes down to two things: that it's a product of their mass, and then also the intensity of the activity being performed. So of course, your heavier athletes, increased mass, they're going to generate more heat than your smaller athletes that are running at the same speed. So as you can imagine, that perfect storm of athletes that may be at risk are going to be your bigger athletes doing sprinting activity where the intensity is higher, particularly in the preseason when it's hotter. And your football athletes, they're not acclimatized, and they're in these pads that don't allow for a lot of conduction of that heat. So keep that in mind. So when looking at exertional heat stroke and how it happens and why it is so dangerous, we look at the mechanism here that's kind of seen on this page. So normally the body is able to tolerate increases in temperature and compensate by radiating heat or evaporation of sweat, but outside factors, as we just talked about, such as increased temperature, humidity, clothing, may make this process more or less effective. Ultimately, for one reason or another, when you have heat stroke in an athlete, this system has failed and results in exertional heat stroke. The hypothalamus is where we regulate temps, so it reacts to increases in core temperature by increasing our sweating, increasing our respiratory rate. And in heat stroke, this mechanism breaks, starts to fail, and thus the body overheats and is no longer able to compensate to regulate those temperatures effectively. Direct thermal insult on the brain is what ends up causing your altered mental status and some of these changes that we're able to recognize as symptoms in our athletes. And then we always think about, is there a genetic predisposition for some athletes? And the fact that exertional heat stroke has been called exercise-induced malignant hypothermia. So there is maybe a genetic predisposition for those that have a family history of malignant hypothermia. Are they more likely to develop this? And ultimately, failure of this thermoregulatory system results in end organ damage, which is why it's so dangerous. Why is this important? It's important to correctly identify these dangerous conditions and also help promote safe participation. But more importantly, we're kind of looking at these athletes, and these are unfortunately 5 athletes that have died in the past 20 years from heat-related illness. Some of them you may recognize. Jordan McNair's the kind of the top left corner here, University of Maryland football player that passed away a few years ago, as well as Corey Stringer, who's in the top right. When looking at athletes across the country, Florida has led the country in heat-related deaths among student athletes, with at least 4 since 2011, with more than 460 student athletes in Florida that were treated for exertional heat stroke throughout the 2017 to 2018. So this is a ton of kids. We're not necessarily going to stop heat stroke from happening, but it's important to recognize it early so that the morbidity and mortality goes significantly down. When we're looking at epidemiology of exertional heat stroke in football, specifically since 1995, there's been 54 reported football player fatalities in a condition that is completely preventable when recognized. And this is pretty unacceptable. And this is why we've had so much legislation and things go through our government to increase the safety, increase awareness and policies that may help prevent these deaths. When they occur, most commonly, they'll occur in August. Almost 1/3 occur more than 2 hours into a practice session. Football players in particular are 11 times more likely to experience heat stroke, more than other sports combined, for a variety of reasons. Probably bigger size comes into factor, the excessive padding that we wear with football that doesn't help us conduct heat, and then the time of the year that we play football typically. So approximately 1/3 of exertional heat-related illnesses occur when a medical profession is not on site, which emphasizes the importance of educating those around you, your players, your coaches, because if they can recognize this and get someone to the correct medical provider, they can help prevent a death, simply put. Here in Florida, we developed the Zachary Martin Act back in 2021. Zachary was a Florida high school football player that passed away in 2017. Parents pushed to have regulations passed to change the way that Florida really mandates treating exertional heat illness. And it passed in the House unanimously in 2020. And really what changed with the Zachary Martin Act is it demanded that there must be an operational AED on school grounds at all times. It must have a clearly marked, publicized location. And teaching those around them how to use this. School employees have to have training in CPR and defibrillator training, and someone has to be present at all athletic events. You need to train your staff on exertional heat stroke, and also establishment of guidelines with wet bulb globe temperature, as well as an emergency action plan. And then you, of course, have to have availability of cold water immersion tubs, and an established plan for on-site cooling prior to transportation, which was a big change in Florida. And with those changes, Florida went from probably mid-tier in the United States for treating heat-related illness to now being #1 in the country for sports safety policy evaluation. And luckily, I've been able to work at a lot of these top states. So I've been lucky to work in places where there are policies and you have the equipment and you have the tools you need to treat this illness. When looking at exertional heat stroke, we look at the risk factors for why our players develop it. Of course, we talked about intensity, humid environments, temperatures going up, but some of the other things that we may look at as predisposing factors that I see a lot, especially in like our marathoners or those in running events, are fever, illness, gastroenteritis, anything that affects our fluid balance or our electrolyte balance prior to race day. Most of the people that come into the tent are confused and we treat them. You ask them if they've been sick at all recently, they've recently had an illness. It's almost as if their body is fighting something else and can't add the proper resources to treat the current condition of heat stroke, and may assist in why would they have that thermoregulatory failure. Anhydrosis, sunburn, dehydration, all reasons why sweat evaporation would be lower, reasons why you couldn't dissipate that heat as well as you would if you did not have those. Medications or drug abuse. So asking our athletes, are they taking diuretics? Are they taking ephedra, antidepressants, TCAs? These are all things that can inhibit sweat response and of course make you more prone to getting exertional heat illness. Alcohol, caffeine, supplements, and heat stroke secondary to kind of supplement use is pretty recognizable within the military and a known cause for why people will develop this. Sleep loss, advanced age, overweight, obesity, these are all things that we're looking at when we're looking at those athletes that develop heat stroke. Although it increases with multi-day events, prolonged events and hot conditions, Heat stroke is actually pretty rare still in ultra endurance events compared to things like marathons, 5Ks, 10Ks. And that really comes down to that intensity factor. When people are in these prolonged multi-day activities or 100-mile events like ultras, their intensity is much, much lower than someone who's doing sprints, who's doing especially sprints with football or higher pace events. When we're talking about heat stroke, this is a word that's going to keep coming up, but it's the wet bulb globe temperature. And we can't speak about heat stroke without speaking about this. And wet bulb globe is a measurement tool that uses ambient temperature, relative humidity, wind, solar radiation from the sun to get a measure, and can be used to monitor the environment conditions during exercise. So if you've ever worked a marathon event or a coverage event or football in the fall, this is something that you'll typically see on the sidelines, but it just calculates how hot it is, what the weather's like, what the wind's like, to kind of give you a true sense of how hot and what that risk of heat stroke is. These activity guidelines are something in the bottom right-hand corner, which has been developed by multiple states, but it's been able to drastically reduce the amount of exertional heat stroke instances when following these guidelines. And really, it just makes sure that athletes have water, they have rest breaks, and as the wet bulb globe goes up, that they mandate more stoppage time, they make sure that they're not wearing excessive pads. And this is even a reason why some marathons get called mid-race, because just the temperature is too high, the humidity is too high, and the risk of heat stroke goes through the roof, and is a reason they'll call the race. Here's a picture of me, young, naive, not sure whether this is the rectal thermometer or the wet bulb globe, but I assure you I've learned a lot since then. So when it comes down to why athletes die from heat stroke, it really comes down to 4 simple things. And it's the inaccurate temperature assessment or misdiagnosis early on. It's no care or delayed treatment. It's ineffective cooling mechanisms, or the fact that the athlete underwent immediate transport and not on-site treatment. When looking at how we measure accurate temperatures when it comes to exertional heat stroke, there's been lots of papers on this, but they all kind of show the same thing. And it's when we look at temperatures that are measuring athletes or people exerting themselves, the only way to measure them centrally as a means from the body is rectally, and it's the only accurate measurement that can be readily performed in the field. There are other ways of measuring core body temperature effectively, but not in our athletic population. Esophageal, pulmonary artery temperature tracking are other ways that can track rapid changes in body heat, but of course we're not doing these. Ingestible thermistors are something that you can also track core temperature accurately, but as you can imagine, you would have to have players all swallowing a thermistor before practice, no vomiting, nothing like that that could be affected. So clearly not practical for the sidelines. And we're really looking at axillary, tympanic membrane, temporal, oral, skin measurement. They're neither valid nor reliable of measuring the true deep body temperature. When we're looking at this graph from the paper above, you can really see this rectal temp can be measured at 102, 103 in these athletes, while all of these oral, axillary, temporal measurements are still sitting around 97, 98. And really the danger comes in the fact that if you're taking those and you don't have a rectal thermometer, you take their oral temperature and it's 98, you may be reassured and say, okay, at least they're not over 104, while very well, if you were to do a rectal or a core temp, they could very well be over 104. If you don't have a thermometer present, if you don't have a rectal thermometer to measure this, treat clinically. If they're confused, it's hot, go ahead and dunk them. The worst that can happen is that the worst that can happen is that they're cold, essentially. They're not going to become hyperthermic from being dunked in a cold tub for 5 to 7 minutes. But the risk of exceeding body temperature is exceedingly high at that point. When we're looking at rectal thermistors, these are kind of 3 common options that we look at. The one on the right is this DataTherm 2, typically runs about $275, with the tubes costing about $12. So as you can see, they're pretty reasonably priced for if you're looking at your school or your athletic organization does not have one. Something like this Welsh Allen kind of Sure Temp, which is a device we typically see in clinics, can be used. It technically is an oral device, but you can use it rectally with probe covers and still be effective. Still runs about $325. And then the YSI monitor probably is one of the better ones, but of course with that comes increased cost, and it has a much longer probe to allow for continuous tracking when the athletes are placed into cold water immersion. When we're looking at heat stroke survival, we always talk about the golden half hour. You have about a half hour where the insult to exertional heat stroke is 100% survival. When we're looking at this rat model from this paper, you can just see that it drops drastically with every 15 minutes that you don't treat it, in regards to percent surviving. When we looked at the human response, though, it looks more like it's 30 minutes, which means we're more durable than rats, which is reassuring. But if anyone knows how we can increase this number to 120% survivability, like on the graph, please let me know, because that would be interesting to find out. So finally, getting back to our journal club paper, looking at the methods of cooling that are available to us. In Doug's paper, they really took a lot of the papers that are out there, and they looked at the rates of which cooling happens and how fast they are able to drop someone's temperature from like 109 down to under 104. Interventions that are cooling at rates of less than 0.1 degrees Celsius per minute. So really most of these down here on the left side of that blue line, they're going to take greater than 30 minutes to reduce temperatures in papers, temperature in patients, and thus they should typically be avoided unless no other options are available. Ultimately, cold water immersion and the options to the right of the graph, which are pretty much all cold water immersion options, are the ones that have the best response to cooling rate. And with ideal cold water immersion, agitating the ice, having multiple people helping you, you can even cool as fast as 0.3 degrees Celsius a minute and cool an athlete from 109 to under 104 in about 8 to 9 minutes, which is really, really fast and really effective. When we're looking at it, cold water immersion is the gold standard for individuals with exertional heat stroke, and should be done on site. Another graph from that paper, that the Journal Club paper, is looking at the body's temperature response to cold water immersion. So one of the points of the paper was that doubters of cold water immersion initially hypothesized that the Curry effect seen in normothermic individuals may be a reason why cold water immersion may be ineffective. When looking in someone with a normal response or a normothermic person on the right side of the graph, you can see that with cold water immersion, their temperature actually slightly increases for about 10 minutes before it gradually starts to drop. These individuals on the left are your hyperthermic individuals, and their response to cold water immersion is drastically different than someone who is normothermic. And really it comes back to that failure of the thermoregulatory system. So in normal people, we get colder, we start to shiver, we start to have peripheral vasoconstriction to try to keep our temperature moderate and without dropping, while someone who's hyperthermic, they have no control over it. So their temperature plummets, which is what we want in returning their temperature below a normal condition. When looking at cooling rates of athletes, depending on treatment modality, looking the black side of the graph, we're looking at cold water immersion, so you can cool someone in less than 15 minutes. The white section, they looked at specifically rotating cold towels over the surface area of the body to cool, which still can be an effective technique, but just not as fast as cold water immersion. And then ultimately the gray area, which was just placing ice bags over the peripheral arteries, which you should probably just empty the bags of ice into a cold water tub and use it for cold water immersion, because it really doesn't do anything, and it can take up to 100 minutes, which isn't going to help you much when you have exertional heat stroke. When we're looking at cold water immersion, for those that haven't seen this before or haven't worked a race, these are 3 different methods for cold water immersion. The typical one you will see in the setup at high schools or the end of a race day or a marathon is the one on the left, which is that Rubbermaid tub. You have the athletes almost fully submerged except for the head in the tub, getting as much surface area as you can in the water. You're having one person stand behind the head, putting a towel under the arms, so that if they are agitated, if they are altered, that they're not thrashing around, that their head's not dropping below, there's no risk of drowning, anything like that. You're having helpers sit on the side of you, put the ice, put the cold water into the tub. Ideally, it would still be in there, especially if practice is going. And then people agitating the water, because that increases the movement of water with convection, and makes the heat transfer to the cold water more effective, helping cool the athlete a little bit faster. These other two methods on the right, this one is a commercially available polar pod, which is just a more available option. You can use your cold water coolers, your drinking coolers at practice, to be poured into this pod. Of course, these zip up, they leave the head out, and they also can leave the arms out in case you need to start IVs. These are more commercially available, but it's harder to get the athlete in and out of these pods, but they can be transported in it, which is nice. And then finally, our kind of lowest budget option, but if nothing else is available, is this taco cooling method, which, as you can imagine, you have to have lots of people involved grabbing on either side, but taking the tarp and pouring ice and cold water on either side and kind of agitating back and forth to cool the athlete. When looking at concerns or controversy regarding cold water immersion in the paper, they tried to address common misconceptions or problems that people may not want to do cold water immersions. And so discomfort to the athlete or patient, and subjectively, at least from my experience, when these people are altered, they're coming into your tent, they may be altered, they may be fighting you because they're not aware of where they are initially. But I can assure you that they're not in discomfort. It's amazing how you put someone their temperature is 105, 107 in an ice water bath, and they act like nothing happened. And it's really just because their body their body temperature is plummeting, and it's almost like they have a light switch moment when they're sitting in that tub and looking at you, and they realize like, oh, where am I? And at that point, you continue to monitor the temperature, and then once they get to 102, you take them out. Risk of drowning is another concern, and kind of, as I said, using that towel under their arms can keep them above water and mitigate that risk. Hypothermic after drop, or the concern that the patient's blood pressure, their blood temperature can drop significantly because of cold water immersion. This is something we're constantly monitoring with rectal temp while they're in there. If you do not have a rectal temp, the recommendations are typically leaving them in for about 15 to 20 minutes before you transport them. Yes, this isn't ideal, but it's something that we can do, is just timing it based on how fast we know that temperature typically drops. If the patient, you don't have a temperature and the patient starts shivering, that may be an indication that their thermoregulatory process is returning and their body is trying to compensate again. And at that point, I would pull the athlete out of the tub. Inability to use supplemental treatments or AEDs is a real risk when it comes down to this. But when they looked at the amount of people that develop cardiac events from heat stroke, that number is pretty exceedingly low. And if they were, you would treat them like any other cardiac arrest that would happen in swimming events or swimming. So you're going to pull them off, you're going to dry them off afterwards. Existing literature both supports the notion that the risk of not cooling the athlete aggressively far outweighs the potentials of any cardiac events in these athletes. And even being in cold water immersion, this does not stop you from using other supplemental treatments. Very regularly, patients in these cold water tanks will get administration of oxygen. You can start IV fluids and IVs on these patients to make sure they're getting hydrated during that time. And then, of course, concerns about feasibility performing without adequate staff. Yes, some of these ways of treating cold water immersion do look like they take multiple people. But ultimately, if you have an athlete, you're by yourself, you're worried about cold water immersion, you got to cool them down as fast as possible. So you got to do what you can. You got to move them to the shade, douse them with water, whatever you have at the time. When it comes down to treatment plan for cold water immersion, this is kind of the quick and dirty of things that I take into account. So really, rectal temp only is the way to measure their core body temperature. Immediate cold water immersion with aggressive cooling if this is suspected. Termination of when the rectal temp approaches 39 degrees Celsius or 102.2 degrees Fahrenheit. Making sure you continually reassess these patients. Don't take the rectal temp out. Continue to monitor it, because bounce back is a typical phenomenon where you'll take the athletes out of the cold tub and you'll notice their temperature starts to rise, and then you'll just put them back in until it drops back below 102. And then once they've cooled the athlete, once you've gotten them below 102, that's the time that you can evacuate and take these patients to the hospital. A common thing that you'll see is that these race days or in marathons, you'll be working with EMS staff. You'll say, we're treating them for exertional heat stroke. And they say, okay, we need to get them to the hospital. And they'll kind of push you to let the patient go to the hospital for further evaluation. But gold standard of care at this time is that we need to cool them on site. It's much higher risk to put them in that EMS where their temperature is still high and risk that temperature going up during their transport. So cool them on site before sending them later. There's a 100% survival rate when immersed within 10 minutes of the actual insult. And so this should be addressed on site with the proper equipment. When looking at these athletes, this is a thermoregulatory failure that results in cell and organ death. So in true exertional heat stroke, patients should be transported to the hospital for further evaluation. That doesn't mean they necessarily have to be admitted, but at least for observation. Within the first 72 hours of exertional heat stroke, you can have metabolic acidosis, you can have increased CPK, rhabdomyolysis, liver enzymes, kidney failure, coagulation disorders as dangerous as increased INR, even DIC, and hypoglycemia. With exertional heat stroke, after the onset of cell destruction, extensive enough to cause end organ damage or failure, the prognosis significantly worsens. This cascade of events with EHS causes death to typically occur within 12 hours or even the first week after exertional heat stroke. It's actually quite rare for someone to die from exertional heat stroke within the first few hours after the incident, but it's really the downstream effects of that cell death, that organ death that happens over the next week or month when many of these athletes end up passing away. When looking at heat acclimatization as a risk factor, what is that? So heat acclimatization is a series of adaptations which the body takes on to prepare for exercise in the heat. So as you acclimatize your body, as you get it used to being in the heat, this lowers your heart rate, body temperatures during exercise. It optimizes your sweat rates and your sweat onset to better dissipate heat, and allows the body to store more water by increasing sweat electrolyte concentration. When looking at heat acclimatization, or what our general recommendations are for our athletes, especially in those fall seasons, these are our kind of Florida recommendations specifically for football, which we now have regulations on. So this is how it should be approached. And so those first 2 days of practice should only be a single practice and helmet only. No practices should be longer than 3 hours in any one day. As we move on to days 3 and 5, you can have single practice in helmets and shoulder pads. Okay to use sleds and dummies, but no full contact at that time. Once we get to the end of the first week and into that second week, we're okay for full pads, full contact, but we still regulate how much time in the heat these athletes have. Warm up, stretching, cool down, everything is involved in that 3 hour continuous hours. And it only counts if you're out in the heat for that environment. Sports such as soccer with goalies, in the case of field hockey, they should not wear full protective equipment or perform activities that would require protective equipment, just like we do in our football players. And this heat acclimatization generally takes about 10 to 14 days and drastically gets our body ready so that it can dissipate heat appropriately and decreases chance of exertional heat stroke. And then, just like any other athletic injury that we see, what about return to play after exertional heat stroke? Recommendations by ACSM came out in 2007 and were updated last year, but they really recommend no exercise for at least 7 days after you're released from medical care after these incidences. If there was any end organ damage, follow up in 1 week after for physical examination, repeating of all laboratory testing, any diagnostic imaging of the affected organs. And then when cleared, you have to have all of those values return to normal before you even start anything, any exercise in the cooled environment, exercise in the heat, anything like that. And then when you are cleared, you can begin first in a cooled environment, gradually increasing your duration, your intensity, and the heat for 2 hours to acclimatize and demonstrate heat tolerance. If you're not showing heat tolerance or you're not able to get back into sport because you keep showing symptoms, generally we'll send our athletes for exercise heat tolerant testing if they haven't been cleared by about 4 to 6 weeks. Heat tolerance testing is not something that's available everywhere, but it's essentially a protocol, which is a 2-hour treadmill exercise test, putting it on 2% grade for about 3 miles per hour in a climactic chamber to 40 degrees Celsius with 40 degrees humidity, and they gradually ramp up their activity. And when they're doing it, they're making sure that their temperature elevates in conjunction with their heart rate, and it's not plateauing during that time. Those with abnormal positive heat tolerance tests, they're classified generally as heat intolerant, especially in the military, and they're prohibited from performing any intense activity until they at least take a second heat tolerance test, which we will generally do about 3 months out from that first test. And it generally takes a pretty prolonged path to get back to heat tolerance testing, especially with athletes that had sequela or end organ damage, can take anywhere from weeks to months, but more commonly it's 2 to 3 months before some of these athletes get back and their body's ready to be heat tolerant again. When looking at EHS rehabilitation in the military, I'm not going to get bogged down in all of these details, but it just goes to show you how long it can really take to get back from a lot of these from heat stroke. Minimum of heat stroke without sequela or end organ damage can take a minimum of 2.5 months, and ones with sequela are 4.5 months. And if you've been proven to be heat intolerant and failed that heat tolerance test, a lot of times you do not pass your military test from there. And finally, I'll kind of end on this, that education is key. There's a lot of good resources on the KSI site when it comes to exertional heat stroke. Educate your athletes, educate your coaches. They're going to be your #1 proponent for helping you identify their teammates that may be acting funny, that something's just not right with them, but also starting treatment. I don't know how many of y'all saw that video of the keeper last week in one of the Spanish games that ran over the bench and grabbed the AED when he saw someone in the fans, one of the fans having cardiac difficulty. But hey, if you're aware, you know what to do in these situations. Your players, your coaches can help you out a lot, especially when you don't have other manpower to help you out. So key takeaways from the talk, things that I thought were important from the paper, is alter mental status with exercise in the heat is heat stroke until proven otherwise, typically a temperature over 104. Cold water immersion is the gold standard of treatment for this and should be done rapidly. Temperature should be measured rectally and maintained during treatment with discontinuation at 102 degrees Fahrenheit. And of course, cool first, transport second. And that's really it. So let me stop sharing. I'll give you all a chance to ask questions. And
first of all, Dr. Troyer, I want to say thank you. This has been a really awesome talk. Definitely one of my favorites. I was surprised to find out that the ultramarathoners were less likely to encounter heat stroke. And I was also surprised to learn that the signs of heat stroke are separate and different from heat exhaustion, and that they're two completely different entities.
Yeah, it's interesting when you say that from the heat exhaustion standpoint. Heat exhaustion is almost like the cardiovascular system can't keep up, and you get collapse, which is one reason that heat exhaustion does not progress to heat stroke, because it's almost like your body is stopping you from exercising, which is creating the heat so that you don't get any hotter, and that's the end of it. Heat exhaustion is how your body should react, and it's kind of like a control delete for the body that kind of shuts you down to stop making you any hotter. Heat stroke is when that process fails and your body is not recognizing it at this point and can't do anything else. And then when it comes to the ultramarathon, it was something interesting that I learned too. You should be concerned about other things in ultramarathon runners that are altered as well. A lot more common to see exercise-induced hyponatremia with a ultramarathon runner compared to someone that's in a marathon or a short distance race. Those guys are constantly drinking water. A lot of times they've been told you need to drink so much water when you're doing this race that a lot of them are taking too much water. They're walking half the race because it's a 100-mile race. And then their sodium drops, and that's why a lot of times these guys are altered. So something to keep an eye out for. But typically the intensity is just not high enough in a lot of the ultramarathon runners. because their body's almost shut down if they're not getting that correct nutrition to be able to keep going.
Right. That makes perfect sense. They're not doing like explosive activity.
Yeah.
Thank you.
And a lot of these guys are pretty small guys. They're not a lot of larger guys. They don't have the body mass. A lot of our sprinters are football players, people like that.
I have a couple questions.
Yeah.
I love learning about this stuff and hearing presentations about it. So my first question is, how long do you wait until you get them down to 102 and you're confident to say that they're safe to go to the hospital? And then how common is it for it to happen that they get down to 102 and then their temperature shoots back up?
Pretty common, actually. And that's why I would say that when you're doing rectal temp, like I gave those 3 examples, and 2 of those were continuous monitoring devices that you literally insert, you leave in, you tape it to their leg, they're waterproof, and you can measure it while they're in the water. The other one with the Welsh Allen one it's an oral temp that you have probe covers on, you insert it, you check it, but then you can't put that in the water. So that's the issue with that one. But when you check it, you leave it in the entire time they're being treated, and you even leave it in when they're going to the hospital a lot of times. So typically when you're treating these, you watch the temp go down, you wait till it gets to 102, you remove them from the water, but you keep monitoring the temp. You just move them into the tent, you put them in one of those lazy boys, and you just continue to monitor. Bounce back is pretty frequent. The other thing you watch for is hypothermia, because some of these guys can go down and then they keep going down. And if it were to drop below 98, at that point, that's when you just take, okay, now we need to move this person to the sunlight for a little bit. And it's just because their body temperature isn't able to regulate as well. So the same reason that they got all the way up, if you're cooling them too long, you're not paying attention, it can go down and drop. So those are the people you need to put the warm blanket on, put them out in the sun for a little bit, and it becomes a delicate balance. I would sit on a lot of these people for probably 5 to 10 minutes at least before you transport them with EMS. They do need, I think that they do need to go to the hospital essentially afterwards a lot of times. Not everyone thinks that way. If you've ever worked a marathon and you see some of these people, if someone's temp was like 104, there may be a little bit altered. You put them in the tank for a minute or 2 and they drop below and that's it. And they're like, all right, I'm pretty good, I'm going to go. I have seen race directors release people home in those cases, but I don't know, from a liability standpoint, I tell all of them, go to the emergency room. Yes, you've just had a heat stroke. You should not be returning to sport for at least a week until you're cleared by your sports physician. And you really need a workup. You need CBC, you need a CMP, you need liver enzymes, CPK, you need a urine to see urine myoglobin, things like that. Because these are all things that we see pretty commonly that affect these athletes. And you can't return them or even think about returning them until those numbers return to normal. I've seen high school soccer girls that get heat stroke. Their liver enzymes are elevated. They don't have other symptoms, but they remain elevated for like weeks at a time. And it takes a while for those liver enzymes to go down, but you can't even think about starting return to play until those return to normal. So that's kind of why some of these things can take so long to get back from. And you know, the reason why it takes forever to get back, and especially with that rehabilitation process, is once that thermoregulatory mechanism is off, it's like it's still altered for a really long time. So if they're exercising in the heat, their temperature will continue to rise pretty rapidly. It's almost like their body has a delayed response to shutting them back down. So you just got to continue to watch them, slowly progress them, start them in climate controlled environment inside before you even think about moving them outside. It can take a while for sure.
Cool, thank you.
Yeah.
And Dr. Troyer, I kind of had something to add to that. You kind of started to answer the question I was going to ask about, you know, I was especially amazed by the length of recovery that you mentioned, both with and without sequela, like 2.5 months, I think is what the table said, or 4.5 up to. And specifically like in the setting of elite athletes that are in superb cardiovascular shape, are in good fitness, basically just wondering, how do you approach that conversation with them, stating like, hey, you know, you might be used to getting back to the field after an injury much quicker than that, but like you said, some of these thermoregulatory mechanisms take time to get back to, and it might be months before you're the same again. I just feel like that would be like a tough conversation in that setting. So
Yeah,
if you
it's
speak to
definitely a
that.
tough conversation. So I try to start my expectations from the beginning. It's not that like, oh, you just had a heat stroke and you were sick today. Like we're going to start training Monday. It's like if they have that and we're having the conversation where they get dunked and they're going to the hospital to check their labs, we say, all right, we're going to follow up in a week, and we'll see where your numbers are at that time. And all of this has to return to normal, and this is going to be a long, drawn out process to make sure your body's ready. It's not as hard as other conversations. It's not like a hamstring or a gastroc where some of these athletes feel great early and they're still at increased risk. Like these people feel pretty terrible, like when they're trying to rehab back. And like you put someone that was running 90 minutes on a soccer field in hot Florida, and they're having trouble running like 2 miles inside on a treadmill at a slow pace before they're saying like, oh man, I feel nauseous. Like I do not feel good. They can tell that their temp's going up. It's not as hard to convince some of these people when they actually try, and they just can't tolerate that exercise. But trying to start those conversations early and set the expectations early, I find is a good way to at least start that conversation.
Yeah, great. Thank you.
Yeah.
Dr. Troyer, this presentation is awesome, especially being like a Florida native that played sports in the summer
Yeah.
year round. I was wondering, is there a specific, I guess, like temperature that is most maximal for recovery? Because I was thinking, like, does cryotherapy ever have a place in the discussion as far as helping out with stroke?
Yeah, I haven't seen anything in regards to cryotherapy as a preventative function in heat stroke. I haven't looked at the literature recently, but I think the last time I looked at it a year or two ago, I mean, the military does a lot of stuff in regards to core body temperature and things that they're trying to do to prevent heat stroke. Some of those are like cold slushy drinks. So they'll drink cold slushy before to kind of line the stomach, and hopefully, some of that doesn't absorb as fast as water, and it decreases their core body temperature before activity so that it maybe has a preventative effect. I haven't seen whether that was effective or not. Military has a lot of research in regards to like forearm cooling, where they'll have these big ice troughs and they'll get in there and they'll put their whole arms in there in between reps and things like that. And I think that they did show that had it was effective in some prevention strategies. So in a sense of cryotherapy being like these ice water troughs, like there may be some literature out there that's effective in helping prevent some of this. And it kind of goes along with making sure you have adequate breaks, that you're making sure these athletes have time in the shade, they have adequate access to water, things that we take for granted all the time and say like, yeah, of course those should be normal. But your football coach down in South Florida that has never heard of any of this stuff has no idea. So it's important to educate them, because a lot of times we're used to the sideline we're used to that sideline care where it's us as the physician, we have an athletic trainer, but not all schools have an athletic trainer. Not all schools have an athletic trainer and other staff that can treat this together. A lot of times these schools only have an athletic trainer, hopefully at their home games, not at away games, not at all practices. And if someone gets recognized as being altered or having heat stroke, you're like pulling the athlete, you're pulling other players to help you get them in the tub, the coaching staff. So the more they're educated on that this is what it looks like, the more ready to go they are in helping you out.
Awesome.
Dr.
Thank
Troy,
you.
I wanted to ask about two-a-days. I don't know if it varies state to state, but how does that play a role? I imagine like you're having greater amounts of exertion, more intensity, especially because it's at the beginning of the season. So has that changed at all, I guess, and maybe in Florida over the years?
So two-a-days are allowed. I have to pull up that slide again, but not in that first week of practice. The first week of practice is no helmets, no pads, no contact. And then at day 6 to 14, I think you can add in full practice. You can add two-a-days, but the rules still apply. It's no more than 3 hours of practice at a single time, no more than 5 hours total during the day. So you can have a 3-hour practice and then a 2-hour practice separated by so many hours. Only one's allowed to be full contact. So they still work into the ability to have things like 2-a-days, but certainly not in that first week. You still got to take a very gradual approach just to get your body ready for that activity. Yeah. Well, I appreciate you guys having me. And if y'all have any questions or anything, I'm sure Nick can share my email with you guys. Just use my Mayo email. And you know, if you're looking to get experience with this, if you don't have any experience with treating exertional heat stroke, go to a big marathon. Go to a big marathon that's hot. Don't go to one in like December. The one that I went to first was the Cincinnati Flying Pig Marathon, which I believe is like in March or April, which is starting to get hot in Cincinnati. And you know, it's probably like 75 degrees, 80 degrees. It's not Florida 95 degrees, but you will see heat stroke at these things. And you know, at a good run marathon, like you shouldn't be worried about not doing everything correctly. They will have emergency personnel who are emergency physicians trained in sports medicine who have these heat stroke tents down to a science. Someone rolls in, someone tells them ahead of time, they're altered, they're already being flipped over, rectal temps being put in, and they have basin after basin where they say, okay, the guy's going to the heat pod. They have 2 people stirring the water. You kind of see how some of these marathons have it down to like a finely tuned machine. And if you haven't ever seen this before, you hear about it, you know, it can be pretty daunting to say like, oh, are we going to like really do a rectal temp on this guy? But like, once you see it 20 times in the same day and people come out whacked out of their mind, and like 20 minutes later, they're like with it. And like 20 minutes ago, they're fighting you. And then all of a sudden they're in the tub and they're like, oh, who are you guys? We're like, we've just been the people hanging out with you in the cold tub past 15 minutes while you were fighting all of us. And they're really, really thankful at the end of it. So if you see a lot of them in the same day, you feel a lot more confident. It's the best way to kind of get thrown in the fire with these things.
Dr. Troyer, this has been one of the best journal clubs we've had. Thank you so much for your time and for such an awesome topic. This is so great, not only in the context of everything that's been going on with all the heat that we've all been experiencing, but really relatable, really awesome topic that was accessible for everybody. So thank you so much. We really appreciate it.
Appreciate it, guys. Y'all have a good one.